Good morning, everybody. This is the second day of CardioEgypt, and we are in the general cardiology track. The session today is about dyslipidemia therapy, how to get the job done safely. It's my pleasure to have Professor Massimo Trecchio in the chairpersons and Professor Tamer Mustafa, and my name is Sameh Emil. The first speaker will be Professor Anna Abreu from Portugal. She will give us a talk about the diet and nutrition for dyslipidemia patients. Professor.
Good morning. Thank you very much for this invitation. Actually, I'm a cardiologist. I'm not a nutritionist. So I'll give you I ran out a program of cardiac rehabilitation, so I can give you my perspective of nutrition for dyslipidemic patients. We know that almost 4,000 deaths from ischemic heart disease in 2019 were attributable to high LDL cholesterol, and that has increased, as you can see on the picture, from the 90s. We have different types of dyslipidemia, as you all know: the primary dyslipidemia with the hereditary base, genetic base, and the secondary dyslipidemias, which are much more frequent and associated to other diseases as diabetes, obesity, hypothyroidism, chronic kidney disease, and others, as with the use of some drugs and mostly with unbalanced lifestyle. So we need to avoid dyslipidemia, to treat the cause when we have a cause treatable, and to treat the problem of dyslipidemia to lower the values of LDL cholesterol. Dyslipidemias may be reverted many times with effective changes in lifestyle, especially diet and regular exercise. And we know that besides the clinical risk factors, we have behavioral factors. And one of those behavioral factors is exactly unhealthy dietary habits, which increase mortality and is a leading cause of non-communicable diseases. We have this paper, which was performed by the Association of Preventive Cardiology, because poor dietary habits remain one of these leading causes of these diseases. And we try to show how to promote healthy nutrition in primary and secondary cardiovascular disease. And to switch to a healthier diet can help, but the lack of implementation of this issue is due to limited training in nutrition. During medical school, doctors are not taught about nutrition, lack of time of doctors, also inadequate reimbursement of nutrition provision, and insufficient resources and community-based support patient barriers. So the promotion of healthy nutritional habits need to go working with all healthcare professionals, with the population, with the patients, and we need to invest in training, education, and increase of awareness. So in primary care, what should be dietary counseling? We know that the promotion of healthy habits needs to adopt a holistic approach. We need to impact someone's life, and besides the nutritionists and dietitians, doctors, nurses, and other allied healthcare professionals need to play a role. We know from a big systematic review that this type of consultations of diet effectively improved dietary quality and control of risk factors in primary care. So primary care physicians need to have motivation and training because they are not comfortable with what they know. We need to overpass barriers to nutritional counseling, and we need also to screen in primary care all the individuals for nutritional habits, and not only high risk or cardiovascular patients. Also, in primary care, we know we don't have the time for a lot of face-to-face appointments, but we can do virtual consultation for nutritional counseling, and nutrition really needs to go through education and public awareness. So these are the key messages of that document I show you, with the seek for training in nutrition and counseling, education of patients, undertaking personalized evaluation of nutritional patterns, and providing holistic approach. Regarding population, what we need to do is to assess the nutritional status and dietary intake, to implement interventions to improve nutritional status, to increase the compliance and minimize barriers, monitor the changes, and of course, maintain interventions at long term, which is difficult many times. Now passing to secondary prevention care and cardiovascular rehabilitation, which is really my area, we need to collect a lot of information about nutrition, about behaviors near our patients. We need to have the measures of weight, height, abdominal circumference, and of course BMI. We need to assess the targets. We need to educate the patient and the family, include models of behavioral change. During cardio rehabilitation programs, we have cooking classes, because it's not only what we eat, it's how we eat, and practitioners must be encouraged to adopt a flexible dietary approach. So this is my team. We have here the key messages for cardiac rehabilitation nutritional counseling. In summary, undertake a detailed assessment of patient dietary habits, encourage and support behavioral changes, and liaise effectively with other members of the team. In our group, we have weekly meetings of the team where the nutritionist is present, and we discuss the more complex cases, because in rehabilitation it's more difficult to control risk factors, namely dyslipidemia, than to increase the functional capacity through exercise. So we know that we can have in blood isolated LDL cholesterol elevation, and this is less common. And what is our dietary management for this? We will do the restriction of trans fats as well as saturated fats. That is the best management. When we have metabolic dyslipidemia, which is the most common, along with high triglycerides, low HDL, we know that we can manage better restricting total calories, especially sugars and refined carbohydrates. You have here in this table what is considered by science healthy or health-neutral foods with evidence-based. By this time, there is a broad consensus. Everybody knows that fruits, vegetables, nuts, that is, of course, healthy, but there are some controversy and a few doubts regarding certain products. Controversy regarding eggs, low-fat milk, cheese, and so on. And here are the foods considered really unhealthy. Everybody knows that processed meats are unhealthy, excess sodium, excess alcohol, sweets and desserts. But there is controversy regarding, for instance, coconut oil or whole fat milk. I'm not going to go through all it's written in these slides because we don't even have the time, but here you have some dietary recommendations for hypercholesterolemia and go through reduction of energy apport, carbohydrates, fats, and alcohol. Regarding cholesterol isolated, alcohol can be allowed, but just in a very small quantity. However, regarding hypertriglyceridemia, we have also recommendations. It's really very important to decrease energy and carbohydrates and saturated fats. But regarding triglyceridemia, alcohol is forbidden. So in this table, you can see the impact of lifestyle changes in in blood lipids. And it's really interesting to see that functional foods, look at the beginning of the slide, functional foods, which are foods like soya and compete with cholesterol for absorption at the bowel, we have these functional foods decreasing 7 to 12% of total cholesterol and LDL cholesterol. When we go to the second topic regarding triglycerides, you have the decrease of more than 10% of triglycerides with reduction or cessation of alcohol intake. And if you go to the third point, we have more than 10% increase of HDL if you increase usual physical activity regularly undertaken. This table is adapted from European Atherosclerosis Society 2019. We have here the guidelines from European Society of Cardiology regarding management of dyslipidemia, but this has some years. It's from 2016. But this table is also interesting because besides showing the impact of specific lifestyle changes on lipid levels, it gives you the level of evidence. And it's interesting to see that interventions that reduce total cholesterol and LDL cholesterol, like the reduction of dietary trans fat and saturated trans fat, have a great effect with level of evidence A. Regarding the second point, interventions of lifestyle to reduce triglycerides, we have the reduction of body weight and the reduction of alcohol intake also have a big effect, as you saw in the table before, and this level of evidence A. And regarding the last point of HDL cholesterol lifestyle interventions, we have the reduction of dietary trans fat and the increase of usual physical activity as a good way of increasing this effect. And it's also level of evidence A. So here you have recommendations to lower LDL cholesterol and improve the overall lipoprotein profile using not the terms protein, fat, carbohydrates, because when you talk to your patients, they don't know exactly what that is. They know, but they cannot choose the food according to that. So here you have the recommendations in diet regarding the types of food, the cereals, the fruit, the vegetables, and here you know that you can use it to be preferred, to be used with moderation, and to be used only occasionally, like in parties and not every day, like chocolate, ice creams, and cakes, as everybody knows. So do never forget that dyslipidemia is many times together with obesity, diabetes, and hypertension. We are treating the patient and not only the disease. So the conclusion of this progress in cardiovascular disease from 2022 says that carbohydrates, fats, and proteins are not harmful in themselves. Food items and preparations are healthy or unhealthy, and this is very important to choose healthy foods rather than choosing macronutrients. And my final message is, and the time is now over, is to say that a heart healthy diet with exercise can avoid and control dyslipidemia in many cases, but surely one size does not fit all. It needs to be personalized, taking into account genes, microbiome, cultural environment, and other factors. So the future guidelines and recommendations should reflect this rapidly changing domain. Education on nutrition for healthcare professionals is necessary to ensure the provision of optimal support and the communication of real and true information to the population, starting early in infancy, and to patients improve awareness of risk and promotes lifestyle changes. Thank you very much for your attention, and please come to our Congress in Athens of EAPC.
Thank you, Professor Anna, for this.
I'm sorry, I'm not.
I am asking about the personalized diet regime for patients who are classified at high risk or very high risk for cardiovascular events. How to amplify this system, how to monitor these patients. Personalized diet regime.
Personalized diet for high-risk
Yes.
cardiovascular
Yes.
patients. Yes. Well, these patients, first of all, many of these patients are not controlled only by diet, of course. Then we need to have pharmacological intervention. And many times when associated to obesity, we need to go to bariatric surgery in many cases. In many cases, we have metabolic syndrome. We need to treat also the other components. For personalized intervention, what we do in my center and what is advised is to have like a multidisciplinary approach. And usually it's the nutritionist who does a complete nutritional evaluation. We also do in our patients the determination of body composition and body, not only body mass, but distribution of muscle and fat. And after intervention of exercise, diet, many times drugs, we evaluate after a period of 2 months or 3 months, we evaluate again the patient in the different components, namely body composition.
So here we give patients general recommendations for diet, not personalized per patients.
No. We adapt the general recommendation to that patient and we give him an individual personalized plan.
Yes.
You're right.
Okay.
Yes. Thank you very much.
Questions?
Thank you, Anna, for this excellent presentation. As an electrophysiologist, I would just to add a comment regarding the point that weight loss and the appropriate diet is not only associated with the reduced level of lipids in the blood or reduced cardiovascular risk, but it also reduces the risk of arrhythmia development, in particular atrial fibrillation. This is a very important key. It's a key to achieve a better, to reduce the burden, the global burden of atrial fibrillation, and also to increase the effectiveness of therapy, whichever they are, drugs or catheter ablation. This is an important point. I don't know if you have any comment on this.
Yes, that is really important. Because many of our patients are really obese or excess weight. What we do is an evaluation before the intervention, the general prevention intervention. We evaluate in cardiovascular sense. We do an echocardiogram. We do a respiratory cardiopulmonary testing. And we also do Holter in almost all patients and mainly in those who already have some signs of, like you say, either they have atrial fibrillation or they have a lot of extrasystulas during the exercise testing. And then after that evaluation and the good monitoring also of magnesium, potassium and everything, because our interventions can change the electrolytes, the environment, not only the lipids, of course. So I think we should look in our dietary plan. We should look at the patient as a whole in terms of risk and not only in terms of lipids.
Okay, my second question about the natural fats. Natural fats.
Sorry?
Natural fats. Whole cream, milk, natural fat. Is it beneficial?
Oh, the
Yes.
natural fats.
Yes.
Okay. What?
Beneficial, cautiously, or should reduction?
Yeah, as I shown here,
Controversy.
there are some, it's not completely said that milk, for instance, it's healthy, especially if it is fat milk. It is something that is very controversial still. What is good is to use unsaturated fats, mainly polyunsaturated fats, take out the trans. And if we take out the processed food, like food already frozen or already preparated, if we take care of using like olive oil, and some kind of products, we will be able to take out those fats that are
If a patient asks you directly, what type of milk is you prefer?
Yeah, usually I don't prescribe the diets, but I have the tables. So what I say is, you can eat all of these. Please be careful with this. So what I say, usually I don't prescribe like in the to drink milk to an adult because it's not even necessary. And I try to say like cereals, fruit, vegetables, olive oil. If we follow a pattern of Mediterranean diet, we will be okay with our patient. It will be good in terms of prognosis for cardiovascular health.
Okay. Thank you, Professor
Thank
Anna.
you very much.
We will move to second speaker. Our Professor Hisham Salahuddin will talk about the LDL cholesterol challenge in patients with high cardiovascular risk, integrating innovative therapies in clinical management.
Mr. Chairman, thank you very much for your kind introduction. I was asked to give this presentation about the LDL challenges in patients with high cardiovascular risk, integrating innovative therapies in clinical management. And this is how the story began. In 1955, one of the first medications to be used to lower cholesterol was nicotinic acid. Fibrates, introduced by clofebrate, was introduced in 1958. And the first enzyme inhibitor for the synthesis of cholesterol was introduced in 1959. However, it was rapidly removed from the market because of its high toxicity. And over the years, statins have become the pantheon, the gold standard of lipid management. It's very clear that we know that the longer we use it, the lower we get the LDL, and the earlier we start the management, the better will be the outcome. And we are having multiple mechanisms by which these medications improve the outcomes. And this is our current status. Multiple medications coming in, and many still in the pipeline, trying to combat our first killer, cardiovascular disease due to atherosclerosis. However, we are having significant challenges in treating our patients. We know that the relevance of cholesterol to cardiovascular mortality. We know that LDL cholesterol and ApoB are actually implicated in each and every step of atherosclerosis, starting from endothelial dysfunction, passing through the different plaques, fatty plaques, and then the complicated plaques, and going finally to the advanced atherosclerotic plaques and the complicated plaques. And this is a lovely slide. This slide actually shows these red dotted lines are showing clearly if you're not having high LDL cholesterol, the ones to the left, by the way. So if you don't have high cholesterol from the very beginning and you're not receiving medications, you will be getting the least possible atherosclerotic events. However, if you are having high LDL and you are treating it late, for instance, at the age of 50 or 60, you will be getting events later. However, this is much worse than if you start your management by the age of 40. On the right side, on the other hand, if you start with a moderate intensity statin early, this is better than giving more intensive lipid-lowering agents later on in life. So these are important facts that we should know. And we have multiple trials. These trials include and registries. The Da Vinci, for instance, showed that 84% of patients are receiving statin monotherapy, and that ezetimibe is used in almost 9% as a combination, and 1% only are receiving PCSK9 inhibitors in combination. And this led to only a 33% at goal according to 2019 guidelines. Of course, a much higher according to the 2016 guidelines. On the other hand, later on, the Santorini showed that 50% of patients were on statin monotherapy, 16% were given ezetimibe combination, and the number receiving PCSK9 inhibitors increased to 5%. However, in spite of this, only 20% of the patients were at goal according to the 2019 guidelines. And there are significant differences among countries regarding those using highest combination therapy. This was found in the Santorini in Portugal, almost 45%, in Spain, 40%, in Italy, 33%, while monotherapy was highest in the UK. We don't have data here in Egypt regarding how many of our patients are receiving combination therapy, but what I'm noticing in practice that many of us are actually using. Maybe this can be a good topic to address in the near future. On the other hand, whatever the underlying disease, if you're having, for instance, atherosclerotic cardiovascular disease, only 20% of the population were at goal, at LDL goal, while the majority, 73%, were not at LDL goals. Even very high-risk patients with atherosclerotic cardiovascular disease, only 19% were at goal. The less risky patients were also not better. They were also managed almost the same, with most of the patients overall, only 20% at goal. So we're having a highly unmet need, and we are having real problems in the management of our hyper or dyslipidemic patients. So overall, 21% of the patients were not receiving at all lipid-lowering therapy. Almost 24% were receiving combination, and more than half of the patients were receiving monotherapy. Another challenge that we're having are that the figures requested in the guidelines, according to the ESC 2019 guidelines, are even getting lower and lower. It's a class 1 to have your LDL cholesterol reduced by 50% or more to a level below 55 milligrams per deciliter in the very high-risk population. It's a class 2B indication to get their LDL cholesterol below 40 if they are having a second vascular event within a previous 2 years. Currently, as we mentioned, the oral LDL cholesterol lowering therapies, the basis of prevention include the lifestyle, as already mentioned. Giving statins still is the gold standard. And combination therapy, whether this would be with using oral medications as ezetimibe, or maybe the newly introduced here in Egypt, bempedoic acid, or some other ongoing under trial still medications as obicetrapib, or maybe the oral PCSK9 inhibitors, or using injectables, including the inclisiran, evinacumab, or the PCSK9 monoclonal antibodies. I'm not going to waste too much time in the effects of statins and how they work. However, they are HMG-CoA reductase inhibitors, and there is a significant linear relationship between LDL cholesterol reduction and cardiovascular disease, because simply for each almost 39 milligram per deciliter reduction in LDL cholesterol, this will be translated to a major vascular event reduction by 20%, a major coronary event reduction by approximately 25%, coronary revascularization reduction by 25%, and almost a 20% reduction in ischemic stroke. And the impact of statins on atherosclerotic plaques is not only, as seen in some trials, as the asteroid halting the progression of atherosclerosis, but may also lead to a significant reduction in some cases of the plaque volumes. However, maybe also one of the effects is the change in the composition of plaques. Many of these plaques, whenever you give high-intensity statin, are becoming, the lipid core becomes less, and the thickness of the capsule or the covering layer becomes thicker, leading to more stable plaques and may be helpful regarding reduction of acute coronary events. Some of the challenges also that we are actually having is the issue related to statin intolerance, which is present in maybe some 9% or so, although in some other registries it shows much higher figures. However, true statin intolerance is not that high as we used to think. We have other medications, including ezetimibe, which targets Niemann-Pick C1-like-1 protein, reducing absorption of cholesterol from the intestine. This usually used in combination with statins leads to an extra almost 20% reduction in LDL cholesterol. However, whenever it's used alone, it's a weak hypolipidemic medication. However, in the racing that was just published a year ago or so, on almost 4,000 patients, the efficacy and safety of moderate intensity statin plus ezetimibe combination was as good as that of high intensity statin regarding the outcomes. However, maybe there was an additional point, which was a reduction, a more reduction in LDL cholesterol, and there was as well maybe less side effects using the combination therapy. Bempedoic acid is also one of the new players. It inhibits ATP citrate lyase, an enzyme upstream of HMG-CoA reductase. However, it has some advantages, although it's a weaker lipid-lowering agent, but has some advantages, including maybe be used in patients having statin intolerance. It improves glucose tolerance and does not increase the diabetes sometimes seen with using high-intensity statin. It also leads to a significant reduction in the high-sensitive CRP, and this is also one of the points and important points in the mechanism of action of this molecule. In the bempedoic acid, the cardiovascular outcomes in statin-intolerant patients, the four-component MACE was significantly reduced, and this adds strength to the evidence that the medication has. Not only that it is a medication which lowers LDL cholesterol, but also has the advantage of having such an important MACE reduction outcome. This was just a 13% relative risk reduction due to a reduction in LDL cholesterol by 22%. This was statistically significant. And maybe using a combination of bempedoic acid plus ezetimibe leads to a further reduction in LDL cholesterol, as seen here in this study, showing a 36% reduction in LDL cholesterol. The phase 2b randomized trial of the oral PCSK9 inhibitor, the MK0616, actually also shows significant promise with a reduction in the higher doses approaching 60% in LDL cholesterol. And so maybe the figures that we are seeing in the guidelines regarding reduction of LDL cholesterol using the different monotherapies as well as the combination therapies will be changed with the introduction of the newer coming medications, and we will be having a stronger armamentarium in treating such patients. Regarding PCSK9 inhibitors, I will not be taking too much time, but it is an important addition for the lowering of LDL cholesterol as it regulates the LDL receptor recycling. We have data from the Fourier as well as from the Odyssey outcome regarding patients having chronic coronary syndrome as well as those having acute coronary syndrome with significant reduction in the primary composite endpoint in both trials. And the evidence is quite clear that the lower the LDL for longer periods, the better it is for cardiovascular risk reduction. And we have as well data from the Huygens, the Pacman trial, and the Glagoff trial showing how these medications may actually reduce the atherosclerotic burden by significantly lowering the LDL cholesterol. And the issues are not only a reduction in LDL cholesterol or the reduction in cardiac events, but also the major adverse limb events, peripheral ischemia, was significantly reduced using evolocumab in some of the trials. We have as well the inclisiran, which is effective and leads to a significant 52% sustained effect of reducing the LDL cholesterol when the medication was given only twice per year. And this is also quite an important addition. Now we are talking about maybe instead of starting monotherapy as recommended in the guidelines, maybe it will be starting in those having extremely high-risk patients to start statin plus ezetimibe, and maybe even from the very beginning in the very high-risk, extremely high-risk patients to start with PCSK-targeted therapy in those having significantly high LDL. Finally, the novel pathways. We have also dealt with the cholesterol ester transport protein, and they do transfer cholesterol esters from HDL to LDL. And we tried these medications and thought they will be improving the HDL, and they do actually improve the HDL. However, the outcomes were quite disappointing in the different studies. And strangely enough, if you go to the genetic forms and the loss of function mutations in the genotypes for CETP, you will find actually that there is a 16% reduction in cardiovascular disease observed for every 10 milligram reduction in LDL cholesterol. Regardless, we are talking about knockout genes or loss of function mutations in the CATP or the HMG-CoA reductase or the PCSK9, almost a 16 or 17% reduction in the outcomes. Most of the trials that acted with the CATP inhibitors actually failed. Maybe the only one which actually led to a positive outcome was on the anicetrapib in the REVEAL study, in which there was a reduction of MACE at 4.1 years of approximately 9%, an additional reduction of 20% at 6.3 years. However, obicetrapib is offering some new data. It's a selective CETP inhibitor undergoing clinical development for reducing both LDL cholesterol and incidence of major adverse cardiovascular events. We have the ROSE study, and they are comparing obicetrapib 5 and 10 milligrams versus placebo, and the outcomes showed that these medications reduce LDL cholesterol by approximately 50%. However, they have also additional benefit of reducing lipoprotein little a by approximately 50%. So they are actually offering some new insights into the mechanism they are acting with. In the ROSE2 trial, on the other hand, having obicetrapib plus ezetimibe, there was also a significant reduction of 63% on the higher doses in the LDL cholesterol, as well as a 55% reduction in the non-HDL cholesterol. So maybe very soon, this will be the shape of the algorithms that we will be using. The newly introduced medications will be coming in, and we will be having to expand the non-statins that we will be using. Finally, a glimpse to the future. Just a few months ago, there was an important trial, although a small one, called the HEART-1 trial on the Verve 101. And these are, for the first time, we are having DNA acted upon. We are aware that there is some anemias that are being treated using DNA editing or the CRISP systems. However, it's not cutting the DNA, it is editing the DNA. And here in the HEART-1, we got 10 patients, and they tried to give them different doses. And this medication, which is the one under trial, which is the Verve 101, is leading to a change in the structure of the gene, leading to a stoppage of the formation of the PCSK9. So in this population, عايزين حد هنا يا شباب. ارجع بقى كده. So in this population, they tried different doses, and the doses actually led to a significant sustained reduction in LDL cholesterol by approximately 55% using this editing of the genes. This is a first in human study, and it's quite promising because probably instead of giving treatment, a daily treatment for the patients, maybe we'll be having a once-in-life trial to stop the gene from producing a specific protein, here PCSK9, so leading finally to a reduction in the a significant reduction in LDL cholesterol. So, Mr. Chairman, my final words are that definitely atherosclerosis is still the #1 killer across the globe. Statins still stay as the main and most important medication to reduce such risk by combating atherosclerosis. We are having a strong armamentarium that will be helping us, in addition to the statins, to lower the risk of our patients. And don't forget that we all aim to live longer and to live a healthier life. Thank you very much.
Thank you very much, Professor Hisham. Excellent as usual. Professor Hisham, the chairman of the working group of dyslipidemia of the Egyptian Society of Cardiology, is interested in this field. So would you expect changes in the guidelines of dyslipidemia, introducing the combination therapy from the start in the upcoming guidelines, or what's your opinion on this?
Yeah, I think it's time to have a change. In many situations, what happens is that clinicians are ahead of the guidelines, and they start earlier than the guidelines, because the guidelines have significant implications. Whenever you're having this in the guidelines, this means maybe cost, maybe some important implications, not just on an individual level. But I'm sure that the guidelines will change, and probably there will be an introduction of the use of a combination with, at least with ezetimibe from the beginning.
Okay, Professor Sham, thank you very much for your elegant presentation. Do you think that in near future we have a triple combination, 3-in-1?
In one tablet, you mean?
One tablet?
Yeah, I'm sure.
Bempedoic acid.
If it is feasible, if it is pharmacologically feasible, we will be having so.
Okay. And which type of patient to start with this triple?
I'm not with starting triple from the very beginning.
Even extreme risk patient?
I'm very much with the starting of a combination therapy, but understanding what we are doing. What we know for fact is that ezetimibe takes some time to give a significant reduction in MACE. It is not like statins. So I'm not very much with the issue of that using moderate intensity statin with ezetimibe, this is equal to giving a high intensity statin, because we have the evidence from high intensity statin. We know, on the other hand, from the racing and from different other studies, that using combination is more tolerated by the patients. So I'm very much with the starting combination therapy with ezetimibe. Maybe bempedoic acid will also be coming in very soon, as we have already hard endpoint outcomes. However, starting with PCSK9 in addition to statin and ezetimibe, I'm not currently with it. Although we are having a very interesting outcome sub-study from the Odyssey, just published few weeks ago. This publication is actually talking about patients having acute coronary syndrome who were not tolerating having their LDL cholesterol lowered below 15. So as per protocol, they stopped the PCSK9 inhibitor. And in spite of stopping the PCSK9 inhibitor because their LDL went down below 15, there was some memory, persistent memory effects present in such patients, so that at the end of the day, their outcomes in spite that the LDL later on started to rise slightly, but still the outcomes were much better in those having significant reduction during the acute coronary event very early. So I think the idea of lowering LDL very rapidly during acute coronary syndrome in the very early time is important. And I think this is even supported by the guidelines, because the guidelines is putting a class 2A indication to give pre-CAF, pre-PCI, even in chronic coronary syndrome, to give them statins ahead of the event.
What about lipoprotein A and ApoB to be used as an adjunctive to LDL reduction?
Lipoprotein little a actually is coming. Maybe we were not talking about it too much because of a very important reason, which is we didn't have too many medications to tackle. Now we are having in the pipeline medications that will be coming in 2025 and 26. And I showed already even one of them, which is the obicetrapib. But we have also microRNA technology coming in regarding this point. I think that in due time, we have to consider. Currently, I'm doing, the guidelines is recommending requesting lipoprotein little a at least once per lifetime. Currently, this is not what I'm doing in my practice. I'm requesting it once in a lifetime, but however, in patients having low LDL and having, for instance, acute coronary events or chronic coronary disease, I'm requesting it routinely, repeatedly, even to such patients.
Thank you very much, Professor Hisham, for this nicely illustrated all the anti-hyperlipidemic agent. And as you mentioned, less than maybe 20 or 25% only reach the goal. So what is your advice about doctor's inertia?
Doctor's inertia. Okay, this is a very good question. I think the problem is a combination. It's not the doctors only. It is awareness for the patients. It is advocating a healthy lifestyle, as our professor here mentioned. It's also related that physicians know the guidelines and try to implement it. Inertia is mainly due to they start a dose and they do not escalate. But maybe the guidelines try to help them by telling them that in most of the patients, you should be starting with high-intensity statin. In most of the patients. Maybe in the elderly, I don't do this. Maybe in some other specific situations. But if you go by the guidelines and physicians know the guidelines, I think they will be, many more patients will be coming to goal.
Thank you.
ممكن مايك هنا لو سمحت؟
First, I congratulate you for a fantastic presentation. Really, very good.
Thank you very much.
One or two things I would like to add here in connection with the BCKS9 acute coronary syndrome. There was just last week, as a matter of fact, article in the American Journal of Cardiology, which have shown that using BCKS9 acutely have decreased the LPA by 30%. Which have been providing now the urgent early start in acute condition with BCKS9. So that is, of course, it's not FDA approved yet, but going to the trials, which is for LP, there's phase 3 trial, which happened. We are already one of the investigator on that, was Olbasiran from Amgen, which is already moving very well. The one from Novartis was Belcarsen. Have been closed. So they bring LPA down by over 90%. So it is, keep tuned. I think LPA is the most atherogenic lipoprotein, more than LDL, and that will be the future treatment.
Thank you very much for your comments. I'm sure this is absolutely right. The only, or almost the only medication we are currently having, which reduces ApoA, lipoprotein little a by approximately 25 to 30%, is the PCSK9 inhibitor. Statins do not reduce and may actually increase lipoprotein little a. So I totally agree with what you are mentioning. And I think when we are having the right medications for the molecule, we will be, it's good that we started now realizing the importance of this dangerous molecule, but I think we will be having medications and we will go on treating it.
Thank you very much. We are running very late, and so I would like to invite Professor Khaled El-Maghrabi to give his lecture regarding the side effect of statins, those related to muscle. Is it true or is it a myth? Yes.
Thank you very much, Mr. Chairman, and thank you very much for audience. My talk today is about statin-associated muscle symptoms. Statin-associated muscle symptoms range in severity from mild to moderate muscle pain, weakness, or fatigue, to potentially life-threatening rhabdomyolysis. Rhabdomyolysis is the rarest and most serious muscle-related adverse event associated with statin treatment. Symptoms and or biochemical abnormalities frequently appear early after beginning treatment. These appear after discontinuation and they recur within days to weeks after re-challenge of statin. Diagnosis of statin-associated muscle symptoms may be difficult, lacking a definite diagnostic test. CK is a biomarker of muscle damage, is commonly used to detect skeletal muscle damage and its severity. However, CK levels are frequently normal in symptomatic patients, assuming statins, while may be increased in asymptomatic patients. CK is non-specific biomarker for statin-induced myopathy, but is currently used in the evaluation of SAMs due to the absence of other specific laboratory tests. The real incidence is still controversial. In fact, randomized clinical trials reported 1.5 to 5 incidence of statin-induced myopathy, while the clinical practice, the frequency appears to be higher. In the PROCESAT study, which traced the prevalence of reported SAMs by the lipid specialists in 23 selected Italian lipid clinics, SAMs were reported by 9% of the cohort. This percentage was higher amongst women, younger, and physical activity. What about the diagnosis of SAMs? The clinical approach in patients with possible SAMs can be summarized in 3 phases. The first one is patient assessment, which consists of general evaluation of clinical features such as statin type and dosage, muscular symptoms in terms of location, timing of onset, biomarkers levels. The second phase is the challenge. What's the means of the challenge, which consists of discontinuation of therapy generally for 2 to 4 weeks in order to verify eventual remission of symptoms. The last phase is re-challenge, either with same statin or another recurring muscular symptoms. After re-challenge, suggests a causal association between statin and SAMs. The statin muscle task force divide or make a score as probable score from 9 to 11, possible score from 7 to 8, unlikely score from 8 to 6, based on location, pattern, time of onset, and time of improvement of symptoms after statin withdrawal, in order to assess patient experience during therapy and to promote patient-physician communication. What about risk factors? Many risk factors in both terms of patient and treatment characteristics seems to increase the risk of developing SAMs. Patient side, female gender, old age, lower body mass index, Asian ethnicity, hypothyroidism, low vitamin D levels, diabetes, renal and hepatic muscle diseases. Carnitine deficiency and variability appear to increase the likelihood of SAM's onset. Exogenous factors such as alcohol consumption, heavy exercise, and major surgery, and genetic markers that may increase the risk of statin toxicity. Genetic variant also play a role. The effect of statin on skeletal muscle function and performance. دي عبارة عن study evaluated the effect of high dose of atorva 80 milligram on muscle strength during 6 months of follow-up without finding any measurable change in muscle function, except for mild increase in plasma CK levels. Other studies compared the statin histology and the plasma concentration to the incidence of myopathy. Despite the dose-dependent nature of SAMs having been demonstrated several studies as well as in clinical practice. A possible explanation of observed increase in risk of SAMs with lipophilic statin treatment in clinical practice may be due to the high drug-drug interactions that are involved into compared to hydrophilic statin. The principal reason of increasing plasma statin concentration is represented by co-prescribed agents which inhibit statin metabolism. Cytochrome B450 enzyme can affect transport proteins involved in statin cell flux, such as organic anion transporting peptides encoded by SLCO1B1 gene. Statins may be grouped into difference in the enzymatic metabolism. Luvastatin, simvastatin, and atorva are mostly metabolized by the cytochrome B A3/4 isoenzyme, while fluvastatin, rosuvastatin, bravastatin are primarily metabolized by the cytochrome B6 enzyme, with a minor contribution to cytochrome B6. Most drugs are metabolized by cytochrome. Approximately one half of these are metabolized by cytochrome B3/A4, such as azole antifungals, macrolide antibiotics, protease inhibitors, tricyclic antidepressant, cyclosporin, amiodarone, and warfarin. Statins are not metabolized by cytochrome B/A4, have risk of drug interactions. This table shows other interaction with statin. There is gene regulation and polymorphism. The trans-cryptogenic approach in patients with solid proved by the statin myopathy compare statin-tolerant patients shows that most of different expressed genes act to balance some of the above unidentified pathways. The most dysregulated differential expressed genes where it is difficult terms of these genes. Several genetic polymorphism involved in statin metabolism and pharmacokinetics may play a role in the pathogenesis of SAMs and explain individual variation of statin tolerance. Another key genes, as seen, patients can be classified into extensive metabolizer, poor metabolizers, and ultra-rapid metabolizers. What about mitochondrial dysfunction? Some evidence correlate with statin myopathy with mitochondrial damage. In vitro studies have been shown difference between lactone statin and acid statins. Lactone size can inhibit mitochondrial complex 3 and respiratory capacity of the muscle cell. HGMG-CoA reductase pathway mediated effects of statin inhibition on HMG are perpetuate pathway, which perpetuation has been linked to possible beneficial pleiotropic effect. Statin negative affect muscle may be due to inhibition of biosynthetic pathway other than cholesterol synthesis. The impairment of these pathways could alter energy metabolism by reducing beta oxidation of fatty acids. All statins used in clinical practice decrease endogenous cholesterol synthesis by inhibition of HMG-CoA reductase enzyme, and therefore all of them may potentially cause SAMs. Statins may be classified according to their pharmacokinetic properties into hydrophilic, lipophilic molecules, depending on their ability to dissolve in water or lipid-containing structures, composed of HMG-CoA analog, a side chain structure that determine solubility. Lipophilic statins can easily enter cell membrane by passive diffusion through membranes, resulting in wide distribution in different tissues, leading to more favorable cardiovascular outcomes. The statins class mainly metabolized by cytochrome B450 enzyme. This is effect of coenzyme 10, the decrease in protein vinylation, coenzyme 10, and also cholesterol have been associated with SAMs. Coenzyme 10 is a fat-soluble quinone that plays an important role in mitochondrial energy. A deficit of coenzyme Co does not seem to be associated with type of statin intensity at duration of treatment. Thus, statins may be interfere with mitochondrial function. Structural abnormalities will be detected in muscle biopsies of patients treated with statin even they did not experience any symptoms. Arginine is a muscle-specific unication protein E ligase playing a central role in introducing proteolysis and muscle atrophy. Arginine, it was found to be active in several conditions, such as cancer, kidney disease, diabetes, and also by fasting. A mechanism that is not well-defined link atropine when increased expression to statin therapy. What about immunological-mediated statin-associated myopathy? Immunomediated cell repair pathways may play a role in statin myopathy. The mean CK levels of ASCP homozygotes were significantly higher, but the very same variant conferred to increased risk of generic myalgia. On the pathophysiology of such association, L1RB5 associated with for code box expression in the spleen, which in turn in the Western regulator of TREG, regulatory T cell immunosuppressive activity. What about neuromuscular conditions? Statin therapy may exacerbate underlying neuromuscular disorders, including myasthenia gravis, polymyositis, inclusion polymyositis, motor neuron disease. Several metabolic myopathies have been associated with SAMs, and very often patients are unaware of disease. Among metabolic disorders associated with statin myopathy, as seen. Pain threshold. Pain threshold can be determinant of statin-related myopathy, when myalgia is a diagnostic criterion. Genetic variant of serotonin receptors are significantly related to myalgia score, but not to serum CK levels. Physical exercise. Exercise together with statin can exacerbate or even trigger SAMs after training a session. CK levels appear to increase more in statin-treated athletes than in athletes not on therapy. The association between high CK levels and age was found only in athletes on statin therapy. Also, vitamin D play a role in statin myopathy. Low vitamin D levels can attenuate lipid-lowering response in atorva treated patients, probably due to the inhibition effect of vitamin D derivatives of HMG reductase inhibitors. Vitamin D deficiency causes osteomalacia, rickets, muscle weakness, and myopathy. In conclusion, statins are generally safe, highly effective pharmacological tools that reduce the burden of atherogenic serum lipoproteins and cardiovascular risk. SAMs are the most common side effect associated with low compliance and discontinuation of lipid-lowering treatment. A step-by-step approach, including careful examination of all other possible factors that may increase risk of statin intolerance, might help patients' compliance to lipid-lowering therapy. SAMs management include different options ranging from lifestyle modification, tested for at least 3-6 months, challenge therapy of switching to different statin and alternative medications such as ion exchange resin, ezetimibe, and PCSK9 inhibitors. A promising perspective is offered by recently developed drugs such as bempedoic acid, and large outcome trials are needed to develop consensus on treatment of plans that weights are cost-benefit of statin use versus pharmacological and non-pharmacological options for long-term reduction of atherosclerotic cardiovascular events. Thank you very much.
Thank you very much, Professor Maghrabi, for this lecture. I have one comment about statin intolerance. We are magnifying this condition. First, most of the people will have some muscle pain and bone pain by advance of age. Second, the actual incidence of statin intolerance and muscle symptoms is only 9%. And many patients will have nocebo effect from statin use. We are magnifying that statin will have side effect. So when one study, they have shown that the patient giving a placebo were having muscle symptoms more than the patient who is receiving actual statin. So even the liver enzymes and they are saying the statin will affect the liver. Now there is advice and there is a study have shown that the statin will be used soon in the treatment of liver cirrhosis. Statin will be anti-fibrotic agent for the liver. So statin are very safe and very clearly used that it will have effect, and the effect of the statin will be reducing the risk of atherosclerosis and its complication. So statins are very safe. This is our comment.
Okay, thank you, Professor Khaled. We are closing the session because we are going beyond the time. Thank you very much for our present. Thank you for our attendees, and see you in next sessions.